Hey, welcome to PodBites, the podcast where we shrink giant topics into tiny, chewable bites. I'm your host, Maha Butt, and today I'm joined by my sister, Sana Butt, to dive into something super duper important: hormonal contraceptives.
Hi everyone, I'm Sana, and yep, we're unpacking all things contraception. Pills, patches, shots, implants, you name it. If it stops ovulation or thickens mucus, we're talking about it today. So get strapped in, grab a coffee and a sweet treat, and join us.
Okay, so give us a sneak peek. What's today's menu looking like?
We'll start by looking at what contraception actually is, just to set the scene and understand what we're even talking about. Then, we'll walk through how hormonal contraceptives work, how they're classified, and then get into the real stars of the show: combined pills, progesterone-only options, emergency contraception, injectables, patches, implants, and vaginal rings. Oh, we'll also touch on who should or shouldn't be using them, based on the current World Health Organization's guidelines.
So whether you're a med student, a clinician, or just curious about how the pill works, this episode's for you. Let's start simple. Sana, when we say contraception, what do we actually mean?
It's basically any deliberate method used to prevent pregnancy after sex. And hormonal contraception is just one of the options in that bigger family, along with condoms, IUDs, sterilization, and even just withdrawal.
And do tell me, how do these hormones stop someone from getting pregnant?
The main strategy is to shut down ovulation. Combined oral contraceptives, or COCs, work by suppressing the release of GnRH, LH, and FSH. That means no egg gets released.
And that's thanks to both the estrogen and progestin in them?
Exactly. Estrogen blocks FSH, so no follicles mature. Progestin thickens the cervical mucus, making it super hard for sperm to get through. And it messes with the uterus and fallopian tubes to block fertilization or implantation. It's like putting up roadblocks everywhere.
All right, now that we know how they work, how are hormonal contraceptives usually classified?
That would be based on how a patient would take them. You've got oral pills. Those are the combined, progesterone-only, emergency, or once-a-month pills. Then there are the injectables, either progestin-only or combined, and the rest, transdermal patches, subdermal implants, and vaginal rings.
A whole buffet of options. It seems like there really is something for everyone. All right, so walk us through the OG combined oral contraceptives.
These are the most commonly used hormonal contraceptives. The estrogen part is usually ethanoestradiol, and for progestin, you'll see norethindrone, levonorgestrel, norgestimate, or drospirenone.
And how do you take them?
Most people take them for 21 days, starting on the 5th day of their period, and then take a 7-day placebo break, during which withdrawal bleeding happens. Altogether, that makes a 28-day cycle.
Seems simple enough as long as someone complies with the schedule. How effective are they?
So if you take them properly, they're almost 100% effective. In developed countries, the annual pregnancy rate is less than 1%. So yes, they really do work.
100%? My, that is quite the number. What's the catch though? What about side effects?
Estrogen-related side effects include things like nausea, breast tenderness, headaches, gallstones, high blood pressure, and the big one, risk of thromboembolism. Progestins can cause mood swings, weight gain, and changes in lipid levels.
I guess you win some, you lose some then. And I assume not everyone's a candidate for these pills, right?
Right. According to the WHO's 2015 guidelines, there are 4 categories of patients when it comes to taking these pills. So for category 1, no restriction. Here, anyone can take them, like teens, post-abortion, fibroids, and even those with iron deficiency anemia. Category 2, benefits need to outweigh the risk here. Like if you're over 40, have migraines, diabetes, or hyperlipidemia, then taking them is maybe not the best idea. For category 3, that's the caution zone, including smokers over the age of 35, postpartum less than 21 days, or if you've got a cholestatic jaundice. Category 4 is the absolute no-go: stroke, coronary artery disease, uncontrolled hypertension, current breast cancer, or suspected pregnancy.
As every doctor should before prescribing something new, it's time to check the meds list. What interacts with COCs?
Anything that revs up liver enzymes, such as phenobarbital, phenytoin, and rifampicin. They make you metabolize the pill faster, which lowers its effectiveness. Think of it like flushing out the drug before it can even work.
All right. So what if someone can't take estrogen?
Then it's time for the mini pill, which is progesterone only. It's taken daily, no breaks. It uses norethindrone or levonorgestrel, and it's great for breastfeeding moms or women with cardiovascular risk.
But it's a bit less reliable, right?
Yeah, slightly higher pregnancy rates and poorer cycle control, but it's a good option when estrogen's off the table.
Okay, what about emergency contraception? When stuff just doesn't go as planned?
That's where postcoital pills come in, which are a high dose of levonorgestrel taken within 72 hours of unprotected sex. It either delays ovulation, stops fertilization, or prevents implantation.
So, plan B, literally. What if you don't want to take a pill every day?
Then consider injectables. DMPA is a progestin-only shot given every 3 months, NETEN every 2 months, and combined injectables are taken monthly.
And they're pretty effective?
Oh yeah, DMPA is 99% effective. Just watch for weight gain, irregular bleeding, and delayed return to fertility.
Now, let's go deeper into the skin and talk about patches. Are they like a sticker that does birth control?
Pretty much. You wear it weekly for 3 weeks, then take a week off. It contains ethinyl estradiol and norelgestromin. Super convenient and great for people who forget pills.
Okay, if someone's choosing between the patch and the pill, how do they compare?
Good question. Patches mean fewer peaks and troughs in hormonal levels, and you skip the GI tract. But they're visible and might fall off. Pills are private, but only if you remember to take them daily. Also, patches might have a slightly higher venous thromboembolism risk, and that's due to higher estrogen exposure.
What if I want the ultimate low maintenance option?
Then you're looking at subdermal implants, which are a tiny tube under the skin, usually in the arm. It releases etonogestrel, lasts 3 years, and is 99.95% effective.
And finally, what's the deal with vaginal rings?
So those are inserted into the vagina, release either estrogen plus progestin or just progestin, and are worn for 3 weeks. Hormones are absorbed through the mucosa, and they're totally self-administered.
All right, now before we put a patch on today's episode, why don't we go through a quick practice question?
Yeah, sure. So let's say we have a 26-year-old woman who presented to us for hormonal contraception, and she refused other methods of contraception like condoms or an IUD, and her past medical history indicates disseminated intravascular coagulation, or DIC, following an abortion due to placental abruption. Which of the following would be the most appropriate contraceptive preparation for our patient? Is it A, ethinyl estradiol, or B, mifepristone, C, ethinyl estradiol with levonorgestrel, or D, levonorgestrel?
The answer would most definitely be D, as it's a progestin-only option, which is the best for our patient with an abnormal coagulation history. In fact, our patient should be warned to avoid estrogens to be on the safe side.
Precisely. We wouldn't want any unexpected deliveries, be it a baby or a blood clot. The key is knowing your patient, their lifestyle, and their risk profile. Contraception isn't a one-size-fits-all, but when matched well, it's a powerful tool for health and autonomy.
Thanks for breaking that down, Sana, and thank you all for listening to PodBites. We'll catch you in the next one.
This is Sana
And Maha,
signing off from PodBites. See you in the next episode. This is Sana
and Maha,
signing off from... Oh, I'll do it again. This is Sana
and Maha.
What? Why's my S? I'm like, okay, again. This is Sana
and Maha,
signing off from PodBites. See you in the next episode. Can I do that again? I said see you. Again. This is Sana
and Maha,
signing off from PodBites.
Again?
Okay. This is Sana
and Maha,
signing off. Oh my God. Okay, sorry, again. This is Sana
and Maha.
I heard a thing. Yeah, okay, again.
Okay, so give us a sneak peek. What's today's menu looking like?
We'll start by looking at what contraception. And for progestin, you'll see norethindrone, levonorgestrel.
Leviosa vingardum.